Talk about our penicillins. What group did our penicillins go into? Beta-lactams, right? How do my beta-lactams work? Cell wall, right? What is my defense from my bugs against my beta-lactam? Alright. What? Go ahead. Okay, so now we're going to get into the nitty-gritty of our antibiotics. When we're going through these, you're going to see things that look like they blend into the slide. That is on purpose. That means that later, after your exam, if you want to use these slides for reference, that you can bring them back to full view, but that I don't need you to know it from this exam, okay? Because there's a lot of bugs and stuff that I don't want you to remember. I want you to remember the big ones, okay? So some of them you're going to see that they blend in. That was me deliberately doing that because I don't want you to know that for the exam, but it's there for completeness for you later, okay? So we have our natural penicillins. These were like our OGs. They're the first ones that were there, and we still use them today a lot. So these are very important for you to look at because you're going to use these. So you have your penicillin G potassium or our Pen G potassium, penicillin G benzothane. So what you see is that they have two different salts or two different formulations when you're looking at those two penicillin Pen Gs, is what we call Pen G. And then you see your penicillin B potassium, or we say Pen BK is typically what you'll hear people call. So those are our three natural. These are our OGs, our first generation of what we had that was there for us to use. Now when you go into your Pen G potassium versus your Pen G benzothane, you see that we have different uses for each of them. So when I'm looking at my Pen G potassium, I'm typically going to use that for my endocarditis that is caused by my strep, okay? We'll talk when we get to endocarditis in part 3 of this antibiotic lecture, but there are two different main causes of endocarditis. So remembering the bug will change your drug, right? Because remember, our drugs have different coverages. They target different bugs. So remember that if we're talking about our Pen G potassium, that we're specifically talking about our strep. And then looking at your Pen G benzothane, this one is IM. I hear that it hurts very, very bad. And so the way that I remember my clinical use for this is I say, oh, if somebody got syphilis, we're like punishing them by giving them this IM medication because it hurts so bad so that they remember not to do that again, okay? So you see that when we have our benzothane, that it's released over a long period of time. So that's why they get that one shot that typically will last them for that entire month. Like the drug is still slowly being released, which is why it hurts. A lot of your IM shots that you see, anything that you see that says depot, most of the time it's gonna hurt. But the reason why is that drug is sitting there and it's slowly being released, slowly being distributed to their body over a longer period of time. So that's why typically we'll see like 1 to 3 months, depending on the formulation of that depot shot, as to how often we're giving it. So specifically looking at your Pen G benzothane, remember your benzothane has been in there for a long time, right? That's why I get that one IM shot, and that's for your syphilis. And then when you look at your Pen BK, we use this for a lot of conditions. And when we're typically talking about it, we're looking at respiratory, and you can also think about their throat, right? So throat and ear infections, and then any of your minor respiratory infections that you have. This does come in a tablet. It's a huge tablet. And if you don't swallow it quick enough, it's disgusting. So just make sure that if you have a patient who, and I always tell providers this, if patients are very sensitive, like they have a bad gag reflex or like they hate like bitter tasting things, a lot of times the patients will end up throwing up these meds, like they can't take them. Also make sure that they can swallow pills, because if they're a horrible pill swallower, that's also going to be a problem if these are, because they're bigger, okay? So oral, throat, ear, respiratory, so just think your Pen BK is kind of like your chest and up, okay? And then our benzothane has been around for a long time. I'm using this for syphilis. They get that one shot. And then when I'm looking at my Pen G potassium, I'm looking at that for my strep endocarditis, specifically your strep endocarditis, okay? All right, this is what I was talking to you about with the spectrum. So let me get my little lights there. When we're looking at our spectrum, spectrums, you see all of the different bugs, and I didn't list them all, but this correlates with this previous slide, right? So palladium is what causes syphilis. Which drug did we just talk about that we can use to treat syphilis? Which salt? Benzathine, right? So this is correlating to say, hey, these are my bugs that I'm covering, right? I told you about strep. Strep can cause, which strep were we worried about? Where was it going? Endocarditis, right? Which med was I using for it? Potassium, right? So whenever I'm looking at those things, I need to see, this is why this makes sense. This is why my bug coverage makes sense. So that's why I was telling you, for you guys, if you want to remember bugs, and it makes sense for you to remember bugs, you can, so that you can think about the clinical use, or you can just remember the clinical use, okay? Also, I need you to remember if that's gram-positive or gram-negative, because I could just say like, hey, this thing has a lot of gram-negative coverage, or this thing only has gram-positive coverage. That's something that will just stick out for you. So when we get to those drugs, I will try to remember to tell you that, because I could potentially just ask you a question that says, hey, what's that one drug that only deals with gram-positive? What's that one drug that only deals with gram-negative, okay? So we'll go through this and we'll keep, you're gonna see all of these, but your clinical uses are correlating with your coverage that you have, your spectrum that those drugs cover. When you look at this and you look at any of your beta-lactams, those bugs and their beta-lactamases are very likely to occur, okay? So when we talk about resistance, a lot of the times, especially if somebody has to get repeat exposure to these drugs, you're likely to see more resistance, right? Because I open my playbook, the bugs are seeing my playbook, and then I close it. Just because I close it doesn't mean that the next time that they don't remember. They're remembering those things, and then they continue to mutate and defeat our drug. So our clinical use, I summarized this again for us, so you see everything listed there. When we talk about gangrene, so our C. preferenges, this, what we would do is we're going to take a very high dose of our PNGK, okay, and then we're giving that with clindamycin, because the clindamycin will kind of help sometimes with the gases that we can see that form sometimes in our patients who have gangrene. So just remember those treatments. So what I did with this is all of this that's bolded, and I think I gave you guys literally the same bolded that I had. Focus on those things. That's what you're pulling out. That's what's standing out for you, okay? What is my use? What is my drug? What is my use? What is my drug? And then at the end of these, I also made summary slides for you to kind of like review what you went over in that section for that drug class. When we're looking at off-label, we see that we have our skin and soft tissue infections, but again, those are the ones that would be caused by strep, which goes back to what we said already. Hey, it has good coverage against strep bugs. So that's why I can use it if my skin is, my SSTI was caused by that strep. And then your pharyngitis, again, we already said, right, my chest and up is typically what I'm dealing with when I'm looking at my natural penicillins, besides my syphilis, okay? But my chest and up, you see that you have your PIN-VK and then you have your PIN-G benzathine that you could use when we're talking about pharyngitis. Again, because it's that IM, you can do that one shot and it'll last them over that entire 28 days or 4 weeks, okay? And then your meningitis. So when we talk about these, they can cross our blood-brain barrier. We like the fact that we have inflammation because that helps actually push our med where we need it to go. But you have to see the origin of that meningitis, because again, I have coverage against strep. I can now treat any strep that is caused, or any meningitis that's caused by strep, because I also have a drug that can cross, right? So that's why you see if it's meningitis that is caused by strep, then yes, I have the ability to use my penicillins, okay, my natural penicillin. Okay, our methicillin. This is just to kind of give you a background, not, when we talk about these are anti-staph penicillins, this is your title. So when we talk about the bug and we talk about staph, remember that staph is king, right? It's one of the hard bugs that we have to try to kill. And so I want to give a nod to the king. So your nafcillin, oxacillin, dicloxacillin. Those are your three that we actually use when we're talking about anti-staph. When you look at methicillin, methicillin is essentially, it was a drug that we used, but it caused a lot of nephrotoxicity. And so that's how we have MRSA, right? Because MRSA was our methicillin resistant. So what we were saying was, hey, MRSA stemmed from us not being able to, or not being able to treat them with any of these anti-staph penicillins. So we don't use that drug anymore, but we still say MRSA, methicillin resistant, right? So that's where you're seeing that name of MRSA come from, but the drug, we don't actually use it. So that's why it's not bolded, and we're just gonna nod to the king, which is our anti-staph meds that we have, okay? So our anti-staph penicillins are your nafcillin, oxacillin, dicloxacillin. Okay, looking at my, yes, no problem.
These three are also the ones that we don't have to worry about renal insurance.
Ta-da. Because of what type of excretion? Biliary excretion, yes, okay. Okay, so looking at my coverage again, right? So I have strep and I have staph, all right? Looking at your clinical use, you have your MSSA, which I typically am not gonna ask you about that, right? Because if they're methicillin sensitive, that makes sense. I can use them against any type of bug that I'm thinking about that has that staph aureus that is sensitive to methicillin. So that's what your MSSA is saying. Your SSTIs, pneumonia, so your osteomyelitis is like any type of infection that they could potentially be having in the bone. So if I can get to that, because remember I had good penetration with these into the bone, I can still use my anti-staph. And then your drug of choice, again, we have another one where we're looking at our endocarditis that is now caused by our staph, okay? So that's where I was telling you, I'm gonna go back real quick. Here, we were looking at our PNG potassium for strep endocarditis. Here, you're looking at your anti-staph when we're specifically looking at our staph endocarditis, okay? So make sure you note the difference. We're gonna look at this again when we look at the third slide deck again, so you'll have a summary, but I just wanted to point that out. And then that note there at the bottom, which is what we just talked about, right? Because of that biliary excretion, I don't have to worry like I do with most of my other meds when I was talking about my penicillins with the renal dose adjusting, okay? This is just a summary showing you all of your anti-staph that you have, how they are administered, which I don't need you to remember in this case. So don't worry about that. Your key organisms, again, don't worry about that. I want you to look at your clinical use. Resistance, we're worried about our beta-lactamases that could be produced, so that's all I need you to know. Making sure that you understand it's not gonna cover MRSA, right? Because it's resistant to that class. If it's methicillin resistant, that means that any of my anti-staphs are not gonna work, okay? So no MRSA coverage. Nothing that we've talked about so far has given us MRSA coverage, okay? And then I want you to look at your special considerations. So when we're talking about our special considerations, most of the time when we're dealing with our pregnant women, if they do need an antibiotic, we're typically not concerned with our penicillins. So penicillins in pregnancy are usually gonna be okay. Our empty stomach, we talked about that. There are some situations where if your patient is complaining a lot about the fact like, hey, whenever I take these meds, I am experiencing like a lot of stomach discomfort, cramping, things like that, then we can tell them our issue is that we could potentially have the decreased bioavailability. So what I like to do is, sometimes I will give it, but typically what I do is I'll say, okay, let's spread it out. You have a meal and then you wait a little bit and then you take your meds and see if that works. But give their food a little bit of time to kind of digest. So that's where you see the 1 hour before or 2 hours after. The 1 hour before is because if I'm taking it on an empty stomach, I also need that medication to go through that ADME process, right? I don't want to add food into the mix because I'm still doing the same thing. So that's why they're waiting an hour versus 2 hours afterwards. When we talk about separating antacids and stuff, that one is 4 hours. Okay, so just kind of keep in your head. This is talking about food. And then when we're looking at that drug-to-drug interaction, probably not gonna really touch on that too much, but when we are looking at your patients who have warfarin, again, hopefully we are not having a lot of patients who are on warfarin. It's an older anticoagulant, and we have newer ones that have less interactions. So don't necessarily worry about that too much. I won't bother y'all with that right now. And then looking at, again, the special considerations, I only want you on this one and this one for these, so the top two. All right. Pregnancy is okay with my penicillins. Okay, your aminopenicillins. So when we're looking at our aminopenicillins, this is the ones that a lot of people hear about, know about, amoxicillin and ampicillin. Very popular medications that we'll prescribe, but what you see here is you have more gram-negative activity, whereas when we were talking before, we also had, so what was our PIN-G focused on? Which bug? Strep, okay? What was my staph penicillins focused on? Staph, right? And so now you see here where we're having a lot of this gram-negative activity, and we're more looking at some of those bugs that are kind of more problems. So we talk about E. coli infection, so that's why you see these prescribed a lot more than our other penicillins. So E. coli, when we talk about H. influenzae, so these are lots of common bugs that we see around that we can still, thankfully sometimes, kill with our aminopenicillins. So when we look at this, we have our beta-lactamase inhibitors that are typically going to be attached to these aminopenicillins. Now, you do not always have to give a beta-lactamase inhibitor with one of these aminopenicillins. Sometimes we will start with just the amoxicillin by itself. So let's say somebody has like otitis media. We'll say, cool, I'm gonna give them amoxicillin. If they have treatment failure and they come back, then we'll go over that whole time frame. But like, let's say they came back and it's been less than 30 days and they're back again, you still see that the ear infection is there. You're like, oh, this might be a resistant bug. So then you'll give them augmentin, which would be your amoxicillin with the clavulanic acid added. So that second portion of what you see, the clavulanic acid, that's your beta-lactamase inhibitor. When you're looking at your ampicillin, and the sulbactam portion, your sulbactam portion is your beta-lactamase inhibitor, okay? So you have your aminopenicillin, and typically we will try to just use that aminopenicillin, and then if we have resistance that occurs, or if we have treatment failure that occurs, we assume that there is resistance, and we will say, all right, now I'm gonna add that beta-lactamase inhibitor. We don't go hard at first because maybe we don't have to, and we don't want them to know that we have this beta-lactamase inhibitor. That's like our secret weapon, okay? So when you're looking at this, some situations, yes, we will automatically jump and we will say we're going automatically to augmentin, which is my amoxicillin with my clavulanic acid. Clavulanic acid portion is the beta-lactamase. And then in the hospital, this ampicillin, sulbactam, or your unison, this is an IV medication that you will see used a lot in your patients who are in the ICU, or like if you have access to IV, this is typically what we will use. And you don't really see ampicillin given alone. It's usually going to be unison together. If you had a patient, so remember with our antimicrobial stewardship, I told you, you want to do IV to PO. You don't want to leave them on there for a long period of time. So as your patient starts to get better, you're trying to get them to that PO formulation, bless you. So what you would do is you would have that IV formulation, and then you would say, oh, what do I have that's comparable? So if you wanted to step them down and put them on PO and they were on unison, you could then go to that ampicillin and you could potentially discharge your patient, okay? Ampicillin, augmentin, and you could potentially discharge your patient. So that is like, these two are equivalent to each other, with one being IV and one of them PO, okay? Treating similar things. They have the same coverage whenever we're looking at them. So when we talk about our amoxicillin, several different formulations that it comes in. We have tablets, we have capsules, we have solutions for our kids, or suspensions, and this is why it's very popular. Typically in the pharmacy, when we see it, we're seeing it in a suspension form for our kiddos. So when we're talking about our clinical uses, respiratory tract infections, acute otitis media is one of the super common ones that you're gonna see with our peds patients. Endocarditis prophylaxis, so like when we talk about patients who are going to the dentist and they're gonna have some type of procedure, we may say, oh, let's put the dentist may put them on amoxicillin, or if they come to you and they tell you that they're about to have a procedure and you know that they have endocarditis, you're gonna say, oh, we need to prophylactically prescribe you this amoxicillin, and then your UTIs. So again, focusing on the bold so that you can kind of remember what's going on in these situations. I don't need you to remember the doses of what we're doing with our amoxicillin. Just know that typically when we're using it for our acute otitis media, it's in our pediatric population. We'll go over this a little bit more with the bugs. Again, my focus is that you're understanding the clinical indications as to why we're using them. I'm not going to be bug heavy, but again, just be aware of it. What I do want to point out to you is going to be our H. pylori. So when we're talking about H. pylori, this is an infection that some people have and they're walking around and they don't know that they even have it. And there are several different ways that you can treat H. pylori. So they get diagnosed, they'll go to the lab, they blow in a bag, they do all these different things to figure out if the person has H. pylori. Come back, you diagnose them, and they're like, yes, we have H. pylori. This is a part of a drug regimen that we use. So amoxicillin will be there, we'll add on a proton pump inhibitor, and you'll see omeprazole. Some you will see clarithromycin. Omeprazole is your proton pump inhibitor. Some providers still do add Pepto-Bismol as well to this regimen, but it just depends on what that provider wants to do. So you still hear different things when we're looking at this. So amoxicillin, your proton pump inhibitor, and then your clarithromycin are what we're using to treat our H. pylori patients. So bolded is our indications that we're using it for, no doses. Okay. When you're looking at your ampicillin, looks kind of similar. You have, again, your respiratory tract infections when we're talking about our oral formulation. I will not say like, oh, this is I want you to know the drug. I'm not gonna necessarily want you to remember which formulation each indication goes to, okay? I won't get that nitty gritty. I will just give you, hey, this is what's wrong with this patient, can I use this drug? Again, when we're looking at our endocarditis prophylaxis, we have that option available. And then your IV, we have sepsis for neonates. So when we talk about sepsis for neonates, they're going to be in the hospital, they will be hospitalized. Depending on how soon they see that there is sepsis, they may be in the NICU. And we will use our ampicillin with our gentamicin or Ampin-Gent to treat those patients, okay? And kind of thinking along those lines of like sepsis. Sepsis is something that's very serious. You don't catch it, the patient can die, right? So I kind of lump this bacteremia into that kind of category. So the bacteremia is essentially they have all this bacteria now just floating around in their bloodstream and we're trying to clear it. So that is where you see the ampicillin typically being used. Like we've seen with some of our other penicillins, we also still have that option to treat our patients who have meningitis. So again, when you have things that can treat these very aggressive, very serious things, remember those because they stand out. You need to know what are your go-tos quickly for those things like meningitis, for things like endocarditis, because if my heart isn't working, I'm dead. If my brain isn't working, I'm dead, right? So those are kind of things that you'll see. Listeria is one of those not super common things, but you have that coverage there for your listeria as well. Okay, we talked about these beta-lactamase inhibitors and we talked about how we can tack them on to different drugs. We specifically saw us tacking it on to our aminopenicillins. But there are other meds that we can see them added to. I just want you to be familiar with the fact that you have a drug, right? One of those penicillins, you're gonna have that drug, and then you're gonna have that beta-lactamase inhibitor attached to it. Understanding that that beta-lactamase inhibitor is not something that has like a lot of antibacterial activity. What its job is doing is to say, hey, I'm here to distract the beta-lactamase, okay? It's specifically doing that. It's not directly helping with that bug, okay? It's like an indirect portion of that antibiotic, okay? So that's what you see here. Your clavulanic acid, you have sulbactam, and you have tazobactam, okay? So these, what that are underlined are your inhibitor portion. This is going to be your medication portion, okay? So understanding the difference between the two. I did want to talk to you about this. So this is kind of what I was just telling you in words, right? So let's say there was some bug in your body, there's no drug, so the bug continues to just grow. If I just add in my beta-lactamase inhibitor, you see that I can kind of decrease that growth, but not really. So that's that minimal, like it doesn't really have antibacterial, so to speak, activity. If I had just my amoxicillin, if my bug was producing beta-lactamases, that's why you don't see a huge difference in that amount of growth. But if I use them together, I can now defeat that bug and decrease, overcome their resistance, the bug's resistance, and decrease that load that we had, okay? So this is just showing you, using them separately, you might not have a great response, but if I use them together, I'm gonna have a very good response, okay? If they are resistant to this, then that's where we start to be like, ID, help, okay? Can I get the ID pharmacist, please? So looking at our augmentin, I kind of touched on it a little bit already. Our clinical use was our acute otitis media. So in our patients who we felt like I gave them amoxicillin, they were resistant to that amoxicillin, I had a treatment failure, and it wasn't because my patient wasn't taking their meds. They took their meds, and for whatever reason, I was not able to overcome that infection. Therefore, I added on my clavulanate, which is my beta-lactamase inhibitor, right? And I extended now my spectrum. So that's where you see now, you see more of that beta-lactamase coverage, and now your drug can stay around for a longer period of time and kill it. It's more effective. Also, you see different respiratory issues, so like pneumonia, rhinosinusitis, and then I like to also call this dogmentin, because if you have bites, okay? So if someone gets bit by a dog, you should remember that we have augmentin that we can use to treat it, so dogmentin, all right? Don't need you to remember all of the different things as far as like how that regimen looks, how long you're using it. Sometimes if you have their records and different, dogmentin, okay? You're using it for dog bites, okay? Just remember that. Don't worry about the treatment duration, don't worry about the prophylactic duration, just know that you're indication. And then this is just FYI, giving you more of the details about the regimen if someone does have a bite. So it's telling you, hey, they have this kind of, if they have this bite, here's the drug, and then this is how you would be using it, giving you the dosing, giving you the duration, all that in a quick snapshot if you ever need that. Okay, my Unison or my ampicillin sulbactam, we already said like our patients with who are gonna need this, they're gonna be pretty sick. We're probably gonna end up hospitalizing them. So when we think about our population, we're starting to see this a lot more because we have a lot of patients who have serious diabetic foot infections. So when we talk about diabetic foot infections, you're gonna have the privilege of seeing them and they smell really bad and sometimes they look really bad, depending on how long the person let their foot be that way. So when we think about it, right, they have all of this sugar kind of floating around in their body. A lot of them have neuropathy and they can't feel their feet, okay? And they will come in sometimes and you're gonna do foot exams probably on your diabetic patients. If you have a diabetic patient, you should always look at their feet for them because most of the time they're not looking at their feet and they're gonna be nasty feet. There's some that are nasty. But sometimes what we see, like we had a patient who came in and their infection, their bone was exposed. And I'm just thinking to myself, like, how did they not feel that? And how did they not smell it? Because as soon as they took off their, it smells really bad. Because it's like their skin is just, it's open, it's being eaten away. And So the person ended up getting admitted, of course, and we were running IV unison on this patient. Now, when you think about these infections, and when you see a diabetic patient, I have to learn to fix my face because my face look at people like, how are you not cleaning your feet? Like, when you take a shower, like that's a part of your body, like are you not scrubbing the feet? And they don't scrub the feet. And so their foot will have, so you can sometimes save them from being admitted to the hospital, save us as a healthcare system a lot of money because if they came in for just a regular checkup, even if it wasn't time for their foot infection, if you see something small, they probably don't feel that. They probably don't know that it's there, and you can treat it at that stage versus like them having this big gaping hole in their foot, okay? So diabetic foot infections are a big thing that we use our unison for. Again, just like we talked about our augmentin, if we had a bite, we can still use our ampicillin for that as well. Sepsis, man, we use other drugs for our sepsis because remember it is more serious, but we have this as an off-label indication. We have seen that it does work. So remember when I told you guys when we have off-label, you can still use it. You can safely still use it. There's research and several studies that have shown, hey, this is why we use this medication for that. And then your intra-abdominal infections. Again, when we think about E. coli, right? E. coli is typically in these areas. So if you go back to that picture that I told you my mom was probably in my mom's school book, you'll see like where different bugs are just chilling. A lot of the times when we're talking about our abdominal infection, we'll see that there's a lot of E. coli resistance. E. coli has a lot of resistance and we treat it so much that that's why they're becoming more resistant. The bug is evolving and therefore our drugs are starting to fail more. So that's why on some of our drugs we can use them, but you'll see, oh, they're second line now, or we will say completely like we don't use them. And in some areas, because the resistance is so bad, you'll see that you'll treat a UTI one way here and then you go somewhere else and they're gonna treat a UTI completely different because we've like created so much resistance in this area, okay? So you'll have several different drugs that can be a drug of choice for something, okay? And then your PID, so if it's not first line, if you see not first line, I'm probably not gonna ask you about that because we're focusing on first line. What's that?
I was gonna say, for this block, would you recommend also eliminate, I see you refer that to this.
That's just because that's ampicillin sulbactam. No, so I put them both, right? It is not a requirement. I'm always giving you a generic. I just like for you guys to hear certain things because you're going to hear them when you go out and you're practicing with people. So that is just a pharmacy me preference. Like on the exams, you probably don't see brand names in some of the other classes. Maybe you will, maybe you won't. But I like to do it because if you keep seeing it, you're gonna be like, oh, I think I kind of remember that. And then you're gonna be around old people who they say stuff like unison because that's how I'm used to saying that, right? So that way you can still be following and not like, oh, what's that? Because I only know generics. Because a lot of people, we don't talk in generics. Some drugs we do, some drugs we don't. Our newer drugs, we like to say the brand name because we can't say the mad generic name. Just say that's what they're called, you know? Yeah. And they're looking at it like you're a pharmacist and you don't know it. No, my mouth works like I don't know how to say that. Why they do that to us? You don't know? Okay. So continuing with your another one of our anti-pseudomonals that we have. So when we talk about this, now we're getting into some of those bigger issues that we have. I can now hit pseudomonas. This is my first time being able to cover and hit that pseudomonas that we talked about so far. So my anti-pseudomonal penicillin that I have is my piperacillin tazobactam or Zosyn. And the way that I like to remember this is Taz. Like I think about him like zooming through y'all remember Tasmanian Devil? Yeah. Right? And so I think about him like just going through everything, and so that just reminds me of like Pseudomonas like flapping around, and then Taz is coming up and like sucking up. That's my brain. So that's how I remember Tazobactam with Taz in it is gonna deal with the Pseudomonas. So looking at this, again I have that Tazobactam which was on our beta lactamase inhibitor slide. So that is now allowing me to get some more antimicrobial coverage. I can beat that bacteria up for a longer period of time because I have this tazobactam in there distracting those beta-lactamases that are being produced, okay? Pretty good coverage. My big thing that I've gained here is that pseudomonal coverage. Now I have the chance to fight Pseudomonas. Whereas all of my other penicillins that I talked about, I did not have that opportunity. So I gained coverage. And then we also have anaerobic coverage, which is another thing that we gained here. With that anaerobic coverage and with some of the other possibilities with us having like the pseudomonal coverage, I see that I can use it for my intra-abdominal infections. Very good for that. My diabetic foot infections, depending on how bad it is, I may need to use this as well. Of course, any Pseudomonas infection, because that is the class of the drug, right, that we were looking at. And then these are kind of similar things that we already talked about, the SSTIs, that has kind of been prevalent throughout all of them. Your endocarditis, we've kind of seen treatment with all of them. If you don't see that it's specific, just remember endocarditis and that'll be enough. And then our CAP, we're gonna talk about community-acquired pneumonia. There will be slides on that, but just for completeness, you'll see it here that you can also potentially use that depending on if your patient is hospitalized, how serious is their pneumonia. We can sometimes use our anti-pseudomonal penicillin, which is our pip-tazo, is what we can also call it. Okay, this is a summary slide of where I essentially took everything that we talked about, the big kind of points, so to speak, and put them here for your clinical uses, for you to say, hey, they're pretty safe in pregnancy because they're my penicillins. Who do I have that can deal with my Pseudomonas? What can I use when I'm talking about my dog bites? All of the things. So I tried to do this after each one of these to kind of keep it together because it's a lot. Okay? So this is your summary slide. So go through the slides and then say, all right, let me try to test myself with this summary slide. What can I answer? Check on learning. What I want you to do here is focus on the allergy, okay? I have a 5-year-old, came to the clinic. His grandmother said that she's certain the last time that he had trouble with his breathing when he took penicillin. Which antibiotic is the best thing to treat this patient? See, we haven't talked about that drug yet, right? We haven't talked about azithromycin, but we do know that we should not pick what? Amoxicillin, because what happened? He almost died though, right? Remember that? But did you die though? He almost did. He had anaphylaxis. She thinks. We don't want her to test it with us in our license. So we're gonna give her something else, okay? Now, when we talk about people who have anaphylaxis and we have that allergy, you can potentially send them to the allergy clinic for them to desensitize that patient. That is you referring them to someone else. If you want to see for sure if they had anaphylaxis, you can send them over there. Do not do that yourself in your clinic, okay? Because you will be trying to stab them with EpiPens and all of the things and panicking. Don't do it. It's not, that's a whole separate procedure that they have a protocol for to try to desensitize a patient if they want to be desensitized. Or if they want to be allergy tested to be sure, like, yes, I am allergic to this thing, okay? Which bacterial coverage was gained from my piperacillin tazobactam compared to my other aminopenicillins that I had? Very good, guys. All right.
Ma'am?
Yes.
With the, say the augmentin, is it come pre-mixed or do you have to give a dose of amoxicillin and then?
It comes together, so it's one pill or solution, but it's together. They have done that for us. They were nice. And you won't see, let me say, I have never seen just like a beta-lactamase inhibitor by itself. Like it's always a combo pill or solution or whatever we made will come out. Which medication is the best choice for a patient with an intra-abdominal infection? Yes, we just talked about them, right? So we had our Zosyn that was available because I have that anaerobic coverage that I can take care of when I'm looking at my Zosyn. I also have the potential, I have that Pseudomonas coverage there also, okay? So these medication is the best choice for our patient with otitis media? What if I told you that they were resistant to amoxicillin? Augmentin, right? My amoxicillin with my clavulanic acid, then I would try in that patient, okay? So, looking at your clinical uses, understanding what you're using the drugs for is the big name of the game, and then trying to remember what class they fall into, your mechanism of action, adverse effects. Can I use this in pregnancy? Yes, no, those kinds of things. Do I need to renally adjust? Yes or no is where we're focusing, okay? So as we walk through these, I'm gonna keep trying to push those things and cement them in your head. Our cephalosporins. So these are still going to be our cell wall inhibitors. They do have some cross reactivity when we're talking about our penicillins, but we're going to look at some of them because some we can potentially use them in those patients. So again, just pointing to the fact that we have these cephalosporins that we're going to be looking at. You have that gram-positive, gram-negative coverage. The only thing that's not on here because they have not updated this wonderful chart that I love so much, John Hopkins made this, but it was a while ago. We have 5th generation cephalosporins, and I have slides in there that'll cover that. But 1st through 5th gen is what we have now. When we're looking at these, kind of similar again to our penicillins. So we have bactericidal, and then that same beta-lactam ring. So what you see here, that can be inhibited or cleaved by our beta-lactamases that we have. When you're looking at this, you have, again, that renal clearance except for your ceftriaxone, which is biliary. What were our other ones that were biliary? What was our abbreviation? NOD, right? Okay, so our anti-staph penicillin, or the other ones that kind of fall into this biliary excretion. So remember your ceftriaxone now with your anti-staph are the only ones that we've looked at to where I don't have to worry about my renal adjustments for, okay? And then looking at this enterococci. So when we talk about coverage and when we talk about bugs, a lot of the times we'll have very prevalent bugs that we're worried about killing, and then some of our meds that we have are inherently just inactive against them. So when we talk about enterococci and our cephalosporins, except for when we're looking at our cephtarline, which is our newer 5th gen, you don't have coverage against your enterococci with your cephs, okay? So for the most part, with your one exception of your 5th gen, which is your cephtarline, you're not going to have any coverage against your enterococci. Looking at my adverse effects, just like our penicillins, for the most part, they're very well tolerated. We have that very low chance of the cross reactivity with our penicillins. There is a chart that you will see, and I'm not going to make y'all remember this. There's a chart that they have where you can look at the different cephalosporins and it'll show you all of their side chains and tell you the likelihood of them having cross reactivity if they were allergic to a penicillin. I just want you to remember the bigger ones where we know they don't cross react, and that's what I'm going to focus on. But if you're ever in practice and let's say that ceph was all you had that could cover whatever that bug was that that patient had, you're probably going to be like, all right, which one can I use that doesn't, what has the least amount of cross reactivity? And then, again, our big concern that we're always worried about is if they almost died though, so our anaphylactic shock, we are not going to try to give them that cephalosporin. So if I experience anaphylaxis with my penicillin, this is off the table for me. This is a general rule. Can you potentially see this in certain situations? Yes, you can. For your exam and for our black and white patient that we have, we are not going to, if they had anaphylaxis, give them a ceph unless I say, and I tell you, hey, this is safely used in a patient who had a penicillin allergy. SJS or Stevens-Johnson syndrome and TENS or toxic epidermal necrolysis are very serious, like skin, it's a skin side effect. So essentially it's like they get treated in the burn center because their skin starts to slough off, or they get a really painful rash over their entire body. I'm sure you will learn about these conditions, but a lot of the times if it's bad enough, We send them to the burn unit. They're on a lot of meds. Some patients, we will induce them into a coma because of the amount of pain that they're in from them. So they can be very serious conditions that your patients will experience. And then, like any other med, that is an IM, IV medication, injection site reaction. When we come back, we will look at this. So we'll be back at 11.
Okay, before everyone heads out to bathroom or whatever, I'm gonna update on the class T-shirt. So the final price is right now is $15. And for the print only, the printing is free. The decal is not. The decal costs $7. So if you do the math, you might as well just buy the T-shirt. If you do the math. But if you have like extra, you have 50, $10, by all means, okay? I put the paper back in the bag, and so you can adjust whatever. And out of that $15, part of it is gonna go back to iPads because we are using them. Any questions?
Thank you.
No, so just like keeps you like
Yourself small. And then the baby still has a fever. So good. Tell Poppy we say thank you.
they didn't tell you what material shirt is.
Listen, I need you to go. Can you go in the bathroom so you can see that towel, the middle bathroom, so I can show you that towel that I was It's right there next to the, it's between the tub and the toilet. To your left, it's not a full towel. No, the other, between the tubs. You see right there, the left part of that towel for your foot?
Older shirt, it's the one for you.
Second
Like
towel. No, the towel that you should butt up is the second shirt.
It's also
It's closer to where the toilet is.
because this
Right there. That is all. I got right my question
never heard of it.
Oh, because he'll probably have some leftover. Well, I'm coming in November.
All right. I mean, most of it is X-rays that we that I've seen in the past. So I wouldn't say I'm confident in MRI. Ultrasound, I know probably not. Yeah. X-rays is cool. I'm probably not good with like.
Yeah. So I'll do analysis,
All that shit is good.
and then when I get to my office, I'll do it. Oh, did you go home?
Cowboy boots on.
Oh, he probably uses the it's an email. I can send you the
Flexing every muscle.
All right. Sometimes we can't hear if y'all can hear us, because I can't hear it if you're up. Huh? That was what? How can you not hear if I can't hear you?
No, we can hear you.
Okay, let's make sure. So, I appreciate how that last, hour, it was fun. Okay, let's keep up this energy. So, what I wanted to talk about now, we are in our steps, and this is where it's gonna be a little bit more nuanced, because we have now 5 different generations essentially that we're covering in this one, class of our separate forms, right? The names and remembering what goes where is super tricky. Okay, so that's gonna be a big focus, because I could just give you a drug and say, hey, what generation is this? And you're like, oh. So I'm gonna give you little hacks. I'm gonna give you little hacks so that you will know where they go, okay? The other thing is that we're gonna talk about coverage in the sense of a lot of gram-positive versus a lot of gram-negative coverage, okay? Because depending on what generation you're looking at, you'll see that this coverage kind of changes, so that's what this picture is showing you. So let's think about this in the terms of being an iPad, right? First semester, we are so positive, we are heavily positive. We like, I got in, I'm good, we're great. And then as time goes on, that negativity starts to creep in, okay? So this is how I try to make you remember. Initially, I'm gram-positive heavy, okay? And then as time goes on, I'm now shifting. What? So I'm not. No, we don't have a gram-negative. We just got a 1 gram negative. Stop. So we start here, right? And you're like more gram-positive. So your first and your second gen, you're more gram-positive, and then you start to see where you're shifting more to your third and your fourth gen as being more heavily gram-negative. Now, when we're looking at this, it doesn't necessarily mean that once you get down here, you lost all of that positive coverage. It it is just not as, it's not as broad as what it was when it was up here, okay? So here, and I have another chart to kind of help you again with looking at the gram positive and the gram negative. But here, I'm just more heavily with my gram positive. Now, when I go to my 5th generation, what you're seeing here with your 5th generation is that you gain coverage with MRSA, all right? Now you can cover MRSA, which is again, one of those bugs, right? Staff is king, I'm worried about MRSA, I'm worried about treating MRSA, so I need to remember what drugs I have that can help me treat my MRSA. So, that is a big thing that you're adding. So it kind of, your 5th gen kind of looks like your 3rd, where it's like teetering, it's like positive, negative, it's like kind of right there in the middle. This one is where you're like, all right, I have MRSA coverage now. So when you look at this chart, I like looking at it this way because this is easier for me and it's more of a picture for me. So I have heavily gram positive, some gram negative, right? And then I see that my positive starts to go down and I'm starting to increase on my negative coverage. And then the same thing here, my positive is going down, I'm increasing on my negative. Now I'm at my 3rd gen. What I see with my 4th gen, oh, I picked up some pseudomonal coverage. Gram positive and negative kind of balanced, right? And then I see my 5th gen. Guess what I have now? Now I have MRSA. So PM. I got my pseudomonal coverage first when I hit that 4th gen, and then I got my MRSA coverage when I hit my 5th gen. 2 big bugs that I need to cover that I typically can't cover. Okay? So now we have 2 things that we talked about that can cover Pseudomonas. What was the one that we just finished talking about? Zosyn, our piptazo. And now I'm telling you that we have some cefepime that can help us with that too. Yes?
Ma'am, can 5th generation also cover Pseudomonas?
No.
Or is it like,
They're separate. And it's expensive too, but it's because it's new. So they're still trying to figure out a lot of that stuff with this, but typically when we're looking at our 5th gen, it's because we're trying to get some good MRSA coverage. This is not us. Also, when we think about our 5th gen and some of our meds, ID will be the only one sometimes that can order certain things. Because we don't want to say or have us be like, ugh, it's MRSA, and we freak out and we automatically go to the biggest gun that we have. Then we start to increase resistance, and we just made this drug. This drug just came out, right? So then you're kind of like, all right, we're going to restrict it, we're going to hold it back. We're going to try our older things that we have for MRSA coverage first, and then if we can't treat them, we may end up, or if there's some type of contraindication as to why they can't use our older drugs, then we'll start to kind of reach for things like this. Super nuanced, way beyond what you have to do right now. You're gonna learn that in phase 2, but like, there's several different things that I can teach you on paper as to what you're gonna do in real life. So we're gonna be sticking with paper. I'll give you real life stories sometimes. Okay, so now what we're doing is, that was very broad. Now we're gonna go through each of our steps, each of our generations, and say, all right, how is this looking? What are we covering? So when we have our 1st generation, most of the time, when we're using these, they are the PO formulation. We do have our cefazolin, which is our IV formulation of our medications. So with my 1st gen, was I more a gram positive or gram negative? Positive, right? So that's where you're gonna see, and that's what I want you to remember. So don't worry about this. I'm not worried about you knowing that. I want you to focus on your clinical uses, okay? And then we were talking about some of our penicillins and how we can get some of that penetration with our blood-brain barrier. Here, I'm not getting that. So if I have something that's like meningitis, can I use this? Not gonna work, okay? So what I want you to remember here are my clinical uses. Remember we talked about Ancef or our cefazolin when we were talking about using our antibiotics prophylactically. So when we're looking at this for our surgeries, this is our 1st gen that we're always typically going to, which makes sense. It's IV, it's gonna be running. That bag is gonna be hanging prior to that procedure. So your Ancef or your cefazolin is your drug of choice that you have when you're using this as a pre-surgery, prophylactically, okay? Looking at, again, our overview, we talked about this already, so not using this for any type of CNS infection because I'm not gonna cross, and then your clinical use is listed again, okay? Chart, table, this is your summary for you to quiz yourself about your first gen meds that we just talked about. Okay. And then you see here where I put like if we couldn't use our anti-staph medications for whatever reason, these are good, they have similar coverage to our anti-staph. What were my anti-staph penicillins? Not. Nacillin, oxacillin, dicloxacillin. Okay, remember them. Okay, my second generation. When I'm looking at my second generation, remember I dropped a little bit of that gram-positive coverage that I have. I picked up a little bit more of my gram-negative coverage. So what I want you to understand here are the drugs that you have that are going to fall into that class. And then again, looking at our clinical uses that we have. Still not crossing that blood-brain barrier, so don't use them for any of those serious infections that we have like meningitis. Still don't have that good coverage over there, okay? So when we're looking at our patients who have acute otitis media, I put them on amoxicillin. My amoxicillin didn't work, so then I said, hey, I'm gonna give you some augmentin. My augmentin isn't working, or your patient continues to come back several times. You will see here that we have a lot of, we can use these as different options for our patients to then treat that acute otitis media, because maybe they're just allergic to my penicillins. And so I will try a different beta-lactam. I'm gonna hit up my cephalosporins. Second gen is what we're typically using for that. When you're looking at your cefuroxime, so as an alternative to my Dogmentin that I had, I could potentially use my cefuroxime for that. And then we talked about this. Your surgical prophylaxis, when we're looking at our second gen, for the most part, we like our Ancef, so our cefazolin. We can use these, but I haven't seen these used that often, okay? So I kind of would think of this as a second line if we were talking about surgical prophylaxis with looking at your cefoxitin, your cefuroxime, or your cefotein. I haven't seen that used for that, not yet. And then your PID is another clinical use that you could see your second gen used for. Sometimes when you talk about your PID, that could be like somebody having, and sometimes it could be secondary to like gonorrhea, trichomonas, things like that. So you will see this being used sometimes in those situations, but not super often. I want you to know these as your second gens, know what your coverage is, know that you're not using it to cross your blood-brain barrier, and then that they're alternatives to what? I have this as an alternative to my augmentin. I have this as an alternative for acute otitis media. So anything that you can use your augmentin for, you essentially have this as a backup if they can't tolerate for whatever reason your augmentin, or if they failed your augmentin. All right, our third gen. So you see that we have one oral option that's available, and then everything else is IV. So I kind of think about these patients as having some other type of like serious type of infection, which is why we're now using our third gen, like it's escalated, okay? With that being said, you now see that when you're looking at these options, now I do have that coverage for those, for meningitis, those more serious infections. So if I had something in my joint, if I'm worried about endocarditis, remember we were talking about like our head and our heart are serious places where we're trying to get there and make sure that we are killing that bug. So now I have that penetration. Now I can get that meningitis and that endocarditis. We see CAP and it says hospitalized. Clearly they have to be hospitalized, right? Because I have my IV formulation that I would be running for these patients. Not one of the first ones that we go to unless we're trying to get if there is some reason as to why they cannot tolerate more of our first line meds, then we will use these. We're gonna go over CAP and that whole algorithm in a little bit, third block. And then now you see also we have ceftriaxone. Remember when we had our syphilis, we had an IM injection. Now we have gonorrhea. We're gonna give them another IM injection with our ceftriaxone. We're gonna try to make them not get gonorrhea again. It is also one that is IM that hurts, right? So you can remember that your ceftriaxone is gonna be used for your gonorrhea also. IM injection that they're getting as one time. And then looking at your ceftazidime or your cefotaxime, your two that have your, well, I can't make you remember it that way. Just remember those two drugs, ceftazidime, ceftaxime. Those are gonna be also for your neonates who have sepsis. So again, they're gonna be hospitalized, they're likely to be in the NICU, you'll see them being used for this. And then we will use this again in conjunction with that ampicillin, because remember we talked about amp and jet. This is also another option for us to use ampicillin with one of these medications as well. Now, looking at your special considerations, again, making sure that you're understanding, hey, these are alternatives, what are they an alternative to? And then the fact that we talked about our CNS penetration, very good CNS penetration. So these are very good drugs when we're talking about meningitis, okay? The one that we use more often is going to be that ceftriaxone. And it's gonna be IV, not the IM. The IM we typically are gonna use for what? Gonorrhea, okay? And then with this neonates, with your, this is something that's important to watch out for because you can make your patient a lot worse. So if you're using ceftriaxone in a neonate, what can happen is that they can form these crystals in their lungs, which is then gonna cause them respiratory distress. Very, very serious. You can also see where they can have that biliary sludging that occurs. So in our younger population, when we're looking at our ceftriaxone, just be aware that this is something that we watch out for, and that's why you don't see your ceftriaxone used, how you see your ceftaxime and your ceftazidime. That's why we skip the ceftriaxone, because it will affect your neonate negatively. The the calcium in their lungs, and then you also have the biliary sludging, okay? Overview, right? So we had gram positive, gram negative, because this is where it was kind of teetering on both. And then you see that you have your ceftazidime. What do we see again? Pseudomonas. Remember I told you about Taz? Taz is carried through there with the pseudomonas. Okay. So ceftazidime, you have some pseudomonas. And then we talked about the blood-brain barrier. So we said, hey, I can now use these for my more serious things like my meningitis. I can use these in my patients who have that endocarditis because I'm gonna actually get that penetration that's going across. And then your cefotaxime, not fantastic, but we do have some coverage against our anaerobes. So if you do have any type of issue, when you see anaerobes, I always think about like abdominal area, okay? So that is also us getting a little bit of benefit with our ceftaxime. And then which one are we avoiding in our neonates? Okay, our fourth gen cephalosporins. So when we talk about our fourth gens, what did we say they gained coverage on when we were looking at our spectrum? No, that was Pseudomonas, fifth gen, right? PM, okay? Pseudomonas first, then our MRSA. So fourth gen, we got some Pseudomonas coverage. These are very good medications. They're broad spectrum medications. We do use them. Remember when we talked about at the very beginning that AMP-C? We talked about we need cefepime. That was like the drug of choice when we had our AMP-C highlighted, we said cefepime. So now you're seeing where your cefepime falls, and then you have that highlighted again for the resistance. We gained our Pseudomonas coverage. Those are the big things that I want you to know about. We still can cross that blood-brain barrier. Very good medications, okay? You're looking at your clinical use. When we talk about these, if somebody is hospitalized, again, we're running this because it's IV, but you see that we can use it in our HAP patients. So our hospital-acquired pneumonia, those are where our patients got pneumonia and they contracted it not in the community, but because they were in the hospital with all of our wonderful bugs that we have there, okay? So you'll see us, we'll start to run our cefepime, also your diabetic foot infections, meningitis, all those serious things, right? Because now I can cross that blood-brain barrier. I also have some anaerobic activity. When I'm talking about anaerobic activity, that means my stomach. That can potentially mean that I have anaerobes floating around in my feet as well. Anytime I think of like a big open wound, I also can be concerned sometimes about my anaerobes. So, anaerobe, you see your intra-abdominal infection, we have the diabetic foot infection. And then that severe, again, is because you're gonna have several levels of tissue, if not muscle, if not bone, exposed, depending on how far that sore has gone on that patient. Okay, our 5th gen. Looking at this is gonna be our ceftaroline. Again, it depends on where you are, if you have keys to order this medication or not. It may vary. So great coverage when we're talking about our gram-positive, gram-negative. We have listeria coverage and we gained our MRSA, okay? When we're looking at this, somebody had asked earlier about like, hey, do we have pseudomonas coverage? It's not good. Like, that's not why we would use this medication. We're more so using this because we need some of that MRSA coverage. Limited anaerobic, and then you see that minimally dose, which is what we saw for most of our antibiotics so far, except for our, I think we have 4 now that we talked about that were not, and they were all biliary. So clinical use, you have your SSTI, which is your skin and soft tissue infection, and then your CAP, which is your community acquired pneumonia. Okay. Another one that we have is going to be our ceftolozine, tazobactam, which we typically would just say Zerbaxa. Again, it looks very similar. What you see here, though, is that we can cover ESBLs, which are very difficult to cover. So those are big bugs. And then our multi-drug resistant pseudomonal coverage. So this one specifically has that pseudomonal coverage that we could get. So when we're looking at this one is in a 5th gen, but its actions kind of mimic kind of like a 3rd gen. And that's kind of how I think about it in my brain. But for your awareness, just remember how it is on the slide. Okay, that's probably easier for you. ESBLs, and then you have your multi-drug resistant pseudomonas. So like you've tried all of your other drugs that you have that cover pseudomonas, and it is resistant to, once you hit 2 or 3, then that's when you're like, okay, I need to just go ahead, let me get my big gun, I'm gonna go to Zerbaxa. So your clinical use, when we have your intra-abdominal infections, we'll use that with some metronidazole to get some good anaerobic coverage for the, which is what our metronidazole is bringing. And then your complicated UTIs, we'll talk about what makes a UTI complicated a little bit later, but complicated UTIs in your HAP and your VAP. It has to be a very complicated UTI for us to admit a person, okay? And then pull out this, which is super like broad spectrum, covering lots of things, resistance. They have to be like super sick for us to do this. Okay. That should say cephalosporins, not penicillins, but the right thing is highlighted. Never noticed that. Okay, summary charts, okay? So everything, like the big highlights that we talked about, that we went through, bless you, are listed here. Seeing what your coverages are as a summary are for the most part listed here. And just making sure that you're understanding the flow of your coverage in general. So on this, I would potentially just be like, hey, here's this bug, and I would tell you if it's gram-positive or gram-negative, what coverage do we have, like which drug can beat this bug, essentially. And then I would, gram-positive, gram-negative is what I'm trying to hint at for you to remember. This is another way for you to look at this and try to remember some of those little tidbits that we already talked about. So this is, again, looking at that coverage as you continue to go. You see that it becomes less positive, more negative, and then kind of starts to balance itself out. When we look at our coverage, looking at where you have your pseudomonal coverage with the exception of your ceftazidime, which is in your 3rd gen. You have that pseudomonal coverage in your 4th gen, and then your pseudomonal coverage, again, but not with both of your 5th gens, okay? And I could probably add that to the chart in a different way. I'll try to figure out how to fix it to add that other pseudomonal coverage. So, what is your mechanism of action of your cefazolin? cell wall inhibitor, right? Which cephalosporin provides adequate coverage for your Pseudomonas? Cefepime, right? What other one that was a third gen that we talked about? No. It has Taz in it, remember? Taz, Pseudomonas, Taz. Okay. All right. Now, our carbapenems. So we are still looking at cell wall inhibitors. So if you are asked about your mechanism, we are still looking at cell wall inhibitors, okay? So carbapenems, monobactams, very good drugs, very broad drugs, which is what you can kind of see here. You see like, oh, I have gram-positive coverage, pretty good gram-positive coverage, and I have some good gram-negative coverage. Definitely looking at like, when can I use these medications to my benefit is kind of what we're talking about these bugs, okay? Remember to only remember your red boxes, don't worry about your MSSAs. So, broad overview, when we talk about this, this is one of the very few classes that we have left when we're looking at our carbapenems that are good against our ESBLs. Because remember those ESBLs was a form of resistance that we were worried about. So again, very good drugs, not something that we typically love to run to unless we have to. So that's why you see it as our last resort for our gram-negative bugs that we can have. So these are going to be our multi-drug resistant. We also have our 5th gen that we could use for this, but like this is like one of you're saving it. You're going to try everything else, and this is your Hail Mary. Like, all right, let me see if I can fix everything with my carbapenem. So you have your gram-positive, no MRSA coverage here, and then looking at your enterococcus. Remember we talked about that enterococcus and how we have some of our bugs where there's inherent resistance, they can't cover it. We talked about that with our cephs. Here you see that I can cover some enterococcus except for my ertapenem. And when we talk about your ertapenem is going to continue to be the exception to the rule. Okay. You see that I also have my Pseudomonas coverage and I have my Acinetobacter coverage as well. So the way that I, except for again with your ERTA. So the way that I remember this is ERTA is not effective against apes. Okay? So my Acinetobacter, my Pseudomonas, and then my enterococci. I'm not doing anything with ERTA. Okay? With those bugs. When I look at my anaerobic coverage, that's a big plus, right? Because we kept having gaps with that anaerobic coverage. So I've gained that here, and then that same dosing that we were worried about, renal dosing is back, okay? So no exception there. When you look at your uses, again, when I tell you anything about anaerobic coverage, what I'm thinking about is any type of abdominal infection, my diabetic foot infection. Those two things should automatically kind of pop up in your head as like, okay, I get to treat these things. I also told you that this is one of the last things that we had that was very good for our ESBL bacteria. So that's why you see this in anything that could be producing an ESBL, anything that is like resistant to all of my other meds that I have available, I can throw these at it and try to see if I can treat it. With my CAP, again, this is going to be your patient who is more severe. So when we look at CAP, we'll talk about it, but you have like where you can treat your patient outpatient, you can send them back home, or they got the pneumonia from the community, but they're very sick and you have to hospitalize them to treat them. So this is for that hospitalized CAP patient that you have where they're going to be super sick and we're going to treat them. Your neutropenia that you have, or your febrile neutropenia, sometimes is going to, you'll see that occur in your patients who are receiving chemo. Their neutrophil count drops. It's a whole thing for you to treat it, and we end up treating with antibiotics to kind of help them with that. And then you have your cellulitis with that sepsis, right? Because now it's spread, and I need something that's going to be very, very aggressive to try to treat my patient. All right? And then you see your infections that we talked about. When we're looking at our pregnant females or pregnant patients, just in general, you see how it's like, I wouldn't prefer this, but if I didn't have any other alternative, then I can use it, right? So like, if you see something like this, most of the time I'm not gonna ask you about that because that's a clinical judgment thing that's gonna involve you and several other people. Pharmacy will probably get involved, you'll have ID get involved to see if there's something else. OB will be involved because the person is pregnant. So there's several different layers to that. So just know that this is not one of the ones that we're just gonna say is clean, safe in pregnancy, okay? Like our other two that we talked about so far. Looking at your Premaxin or your imipenem cilastatin. When we talk about this, your imipenem can be broken down very quickly and it has a nephrotoxic metabolite. Whenever you have this and you add on that cilastin to it, or your cilastatin to it, this is helping you try to prevent how much that is broken down to where it's not a nephrotoxic metabolite. So it's trying to help us protect the kidneys, okay? So this is not how we've seen so far where there were beta-lactamase inhibitors. This is more so to help with the stability of the imipenem. This is not a beta-lactamase inhibitor, okay? So I know it's written a slash and it looks how we saw like our tazobactam, our sulbactam. This is not the same thing. This is to help our stability of the imipenem. You have also your meropenem and your ertapenem. Remember, your ertapenem was not effective against A, right? So I wasn't going to be able to treat my Pseudomonas, my Acinetobacter, or my Enterococcus when I'm looking at my ertapenem. All right? What else do we notice about all three of these? I'm seriously sick because they're all IV, right? You have to now have me hospitalized because I'm not doing so hot. Okay? But remember what your ertapenem does not cover. Okay? Your adverse effects, these are they're very well tolerated for the most part, right? Just like any other med that we talked about before, if I am going above my therapeutic window, if I give them too much, if I have something that needs to be renally dosed and I don't renally dose in that patient who has poor creatinine clearance, I can expect to start seeing accumulation. I can expect to start seeing more of those adverse effects, right? So when you're looking at this, nausea, vomiting, rashes, those are typical things that we see in a lot of our patients who are going to take any type of antibiotic. But in your patients who have an underlying history of epilepsy, we can see that with higher doses, and I don't need you to remember the cutoff or the dose, just remember with higher doses, I'm likely to start seeing seizures in those patients. They already have a lower seizure threshold. Now I'm giving them a high dose of this medication, which could potentially make them more prone to actually have a seizure, okay? So in those patients with epilepsy, you're very likely to see with a higher dose of your imipenem, you're likely to see that they'll have a seizure. Looking at your anaphylactic reactions. Remember, this is our, but did they almost die though, right? This is one of those things where when we're looking at our penicillins, if they have that anaphylactic reaction with a penicillin, they're likely to also have this occur with my carbapenems, okay? So when you see cross-reactivity or high likelihood of a cross-reactivity, that's what it's talking about, right? So less than 5%, that risk. If you want to try to test the risk, remember we're referring them, you're not doing that because you went through IPAP and you don't want to lose your license, okay? You didn't do this for no reason. All right, so this is again just showing you all of your different gaps, right? So remember how we said our ertapenem was not going to cover that Pseudomonas? You see, like it's not covering that Pseudomonas. We said that it doesn't cover Enterococcus. You see that your Enterococcus isn't highlighted here. So remember 8 for your ertapenem. Your ertapenem had all of the exceptions, okay? Monobactam. The way that we can remember our monobactam is it's only one. Ashtriodam is your monobactam, okay? And it's the only one that falls into this class. You see that here, this is a strictly gram-negative drug, okay? So anything that has any type of gram-positive activity, it is not going to work, all right? So Ashtriodam is strictly gram-negative. And when we look at, I'm going to go back. When we look at our chart, where is it? Is it on here? There it is. When we look at our chart, you see all of this is white. It's only covering my gram-negative, okay? So your Ashtriodam is right above this carbapenem one. And that's how you can kind of, you like pictures, hey, I didn't see anything on the gram-positive side, heavy gram-negative. You see that I have some pseudomonal coverage, I have my Enterobacteriaceae coverage, I have great coverage with this if it is a gram-negative bug, good drug. I don't have any anaerobic activity though, okay? So when you think about like your ceftazidime, your aminoglycosides, which we're gonna talk about, you'll see that this is kind of similar coverage to those. No cross-reactivity with our beta-lactams unless they have had a reaction to your ceftazidime. So what that means is if you have somebody who is allergic to your penicillins, if you have somebody who is allergic to your cephalosporins, except for ceftazidime, this drug you can safely use in those patients. Okay? But make sure that that bug that they have will be covered by this. Because remember, I don't have any gram-positive coverage. I don't have any anaerobic coverage. Okay? So I can't, don't just be like, oh, well, it's an allergy to penicillin. That must mean that I can use my astritinib. That's not what that means. Because if my bug is a gram-positive bug, it's still not going to work. Okay? Our clinical use, very serious infections that we will have, and then you see that you have any of our pneumonias that we can talk about. Typically, there will be hospitalized. So your CAP, your hospitalized version of that, your HAP, which is your hospital-acquired pneumonia, and your VAP, which is your ventilator-acquired pneumonia. So after sometimes we put our patients on a ventilator, they can acquire pneumonia as well. So that's your VAP. And then looking at our patients where, hey, if I know that they can't take that penicillin, they can't tolerate that cephalosporin outside of our ceftazidime, then this is a good alternative for me to use in my patients, and it's also safe in pregnancy, okay? So now we're back to, I'm good, I can use this in pregnancy. Our carbapenems, we were like, man, okay? Glycopeptides, bless you. Glycopeptides, still in our cell wall inhibitor era, okay? The big one that we're gonna talk about is gonna be our bank. So essentially the same thing of what we were looking at before, that diala, we're trying to mess with that cell wall. We're tricking that bacteria to incorporate the drug instead of incorporating and making their wall, okay, at PVP. So our agents that we have, you have several. You have your vancomycin, your ortavancin, telavancin, and dalbavancin. The one that you use the most is going to be your vancomycin. There's a lot of dosing that goes into vancomycin. Vancomycin is like a lot of work, but it's a great drug and we use it a lot. If you have questions about the dosing, because I'm not going to make you remember how to dose it or do the calculations and all this stuff for it, but if you have questions about the dosing, you're unsure, you need to contact pharmacy, okay? Because with this, you'll give a loading dose, which is going to be a very high dose that you would give them, and then you drop it down depending on what condition they have for their maintenance dose. And we check levels of this once it hits steady state. We check levels, and we're like, all right, hey, what do I need to do with my dose? Is it where I thought it was going to be? Did I hit my? Some people will look at the peak, and some will look at the trough, depending on where you are. Most people will pull those levels, and they'll say, hey, I'm within my therapeutic window. I'm good. Okay. If somebody is in the ICU and they're super sick, we'll pull these levels probably a couple of times just to make sure that their renal function is still not fluctuating crazy and that they're eliminating that drug the right way and we don't have accumulation. And we'll talk about why we're worried about that accumulation. So your mechanism of action and time-dependent killing, we already said the cell wall, and then you see that it's bactericidal. It takes a little bit longer to work. It is an IV medication, so most of the time we're giving this, if there is a PO formulation, and that's where you'll see down here where it says active against that C. diff. If we were trying to treat C. diff, we would give this orally because it's not absorbed. That is the only time that you should see vancomycin given orally is for C. diff. So when you're ordering it, make sure that you're picking your IV if you're treating any type of infection versus if you're treating C. diff. Your IV formulation is helping with that, okay? Also, you see here some good activity. We have our problem child is being covered, MRSA coverage. So that's why we use Vanco a lot. When we start to have vancomycin resistant bugs, then we're like, oh crap, we gotta dig deeper in, we gotta go more broad spectrum, but typically we're right here and we're okay. So what do I use my oral formulation of bank for? Okay. All right, adverse reactions. Now, we continue to check these labs and we pull level, our bank levels, because we need to make sure that we're in that therapeutic window. When we go outside of this therapeutic window and with higher doses, we are likely to see a lot of these side effects occur. With our vancomycin flushing syndrome, you'll probably still hear people say this. We used to call it red man or redneck syndrome, see why they changed the name. So you will still hear people say that though. This is more so because of how we're running it. So if we're running the medication too fast, you'll see that they'll start to flush. They'll get like a red rash all over their body, which is why they call it red man. But vancomycin flushing syndrome is now the proper name for you to use for that. So what you're trying to do is essentially spread out them running it for at least an hour. As a key to what we do, we typically say every 500 milligrams, they'll get 30 minutes to run that 500 milligrams. But if your dose is 500 milligrams, you at least need to start in an hour so that you can prevent this flushing from happening to your patient. Looking at your nephrotoxicity and your ototoxicity, this is essentially saying that because that dose, right, I had a higher dose or I had accumulation for whatever reason, I'm likely to see nephrotoxicity and ototoxicity occur. Especially if I have it combined with, because remember we use sometimes our antibiotics synergistically, if I have it combined with another drug that has ototoxicity or nephrotoxicity, now I've increased my risk of having these side effects, okay? So most of the time whenever when we see these occur, it can be reversible. So once somebody tells you like, oh, my ears are ringing, back off the bank, okay? Pull it off. If you see that their creatinine clearance, their serum creatinine is starting to get affected, you need to start worrying about that nephrotoxicity, okay? Clearance, I already told you we have renal, we're worried about that, right? Which is why we're pulling our levels. Pregnancy, looking at this, you can see that it does cross, but they're not, how do I say it? What we're worried about are the side effects that we would typically see in that adult. So you see here the hearing loss or the nephrotoxicity. So again, the ototoxicity or the nephrotoxicity. But when we talk about like the incidence of us being able to say, hey, this is associated to bank, that's why you see they have not been reported. So safe-ish, I have seen it used in pregnant women because if that's all we have, guess what we're gonna do? We're gonna use it because you have to save the host, right? So it's all about like the woman isn't alive. So for this one, yes, you can see some of the levels in the across that placenta, but are they harmful? We don't have any data that suggests that right now. So for this, you can use this in a pregnant patient. We already talked about the fact that we don't have that good oral absorption, right? So the only time that I'm using this was for what? C. diff. If I'm using this orally, it is for C. diff. And I have MRSA coverage when I'm talking about my bank. Looking at my coverage, we talked about this already, so this is again like a recap of what we did. So you have several different things. Your patient is very ill if you're looking at bank. So we're talking about MRSA coverage. We're talking about if there's resistance to any of our other beta-lactams that I could have potentially used for MRSA coverage. You're talking about some of your sepsis. When you have osteomyelitis, like very serious conditions, we have very, very good coverage when we're talking about our MRSA. Meningitis, so you will typically see this used very often. We use this, like, I don't think there was a day that I was in the hospital where I didn't come across us using bank, okay? And then we talked about our oral dosing. We'll talk about fidaxomicin when we talk about our macrolides, but guidelines have changed depending on where you are. Fidaxomicin is now first line, and then you use bank as like a second line medication now. But we used to have only bank. Fidaxomicin is a newer thing that we've started to use for C. diff. All right. Looking at our cyclic polypeptides, still in our cell wall inhibitors, you have your bacitracin. So when we talk about this, this is something that you can get over the counter, but we also have it, bless you, available. You see again, we have something that is now primarily gram-positive, topical, something that we probably all have around where we're using it for our little cuts and our scrapes, little minor issues that a patient can have. Also, you see this used for ocular infections. We'll have this, we tell people typically to use it at night because it can sometimes blur their vision. So depending on what formulation, if it's a drop versus if it's an ointment, a lot of the ointments we tell patients to use at night because it puts like an oily film over their eye and they can't see it. Oh, and then the hypersensitivity. So if they can't take neomycin, they may not likely be able to take your bacitracin. Okay, so just be aware of that. Wrong way. Okay, we are in a new era. We are talking about membrane now and not wall. Okay, so all of the other ones were cell wall. Now we are cell membrane. Okay. Looking at your cell membrane inhibitor, we have our daptomycin that is available here. So looking at this, mechanism of action has now changed, right? I'm not worried about that diala. Now what I'm doing is I'm binding to that cell membrane, and essentially what happens is it causes depolarization and the cell leaks. So it leaks out all of its contents. So with that, bactericidal. This we were seeing a lot of time dependent. Now you see that we're concentration dependent killing here. Adverse effects. So when we talked about our daptomycin, what I want you to remember with this is that our lung surfactants will cause that eosinophilic pneumonia. When daptomycin hits those lung surfactants, it inactivates the lungs, it inactivates the medication, okay? So then what happens is you'll start to see eosinophilic pneumonia because they have a lot of accumulation of that drug, okay? The other thing that you'll see is myopathy, and with myopathy, and we'll talk about this when we talk about statins because it's also a big adverse effect there, we monitor that CK, that creatinine kinase. Every week that they're going to be on Dapto, you're going to be monitoring that because you need to make sure that we don't hit myopathy, which could possibly turn into rhabdo and all of the things, okay? So if your patient starts to complain of muscle pain, that's your hint that, hey, this may occur. And even if you pull that lab, let's say last week and it's not time, it's only been 3 or 4 days and they're complaining of muscle pain, pull it again and see if those levels went up, that CK level went up. Renally dosed, good for our pregnant women, so we can potentially use it in our pregnant patients. So let's see. Looking at our coverage, I have gram positive, my gram negative. I'm very good with like things that are resistant, right? So good medication. And now my VRE drugs, right? So if I'm bank resistant, remember when I was telling you about our bank, we had that burst of coverage, and I said we're in deep trouble if something is resistant to our bank because now we have to dig a little bit deeper. So that's where you'll see our Dapto used. So remember VRE, vancomycin resistant enterococci, or anything that is resistant to our bank, we could go here. Our uses, SSTIs, MRSA, any type of MRSA infection, your endocarditis, osteomyelitis, remember the bones, all of our more serious things. Why can I not use it for my lung infections? I'm inactivated by those lung surfactants, okay? So that ties into that adverse effect that we saw of the accumulation, okay? So no lung types of diseases can we use this. So any of our pulmonary infections, it can't get to the site of infection. If I can't get to the site of infection, I'm not going to be effective there. And then we'll just stop here because it's 1 minute and I'm going to not finish that. So we'll start here. You said push? No, because it's 10 slides. We'll finish it tomorrow. So next week we're going to have a guest lecturer. Our ID pharmacist, I got the ID pharmacist from the hospital to come on over. She's going to teach the fungal infection lecture. And then next week we'll also flip the classroom to where you guys will teach your working groups It is not gonna be homework, you're gonna work during class to do it, I'll give you guys like 20 minutes, I'll give you what you're gonna do, we'll do it that day, we'll go over the lecture, it will be fun, it is not something that's supposed to make y'all angry, and people get angry. It is to keep you interacting and keep us engaged, okay? Don't make them faces, we have a good day today. I'll see y'all tomorrow.